I have a story about my son. Even though he's only 8, he taught me a valuable lesson. He contracted salmonella 4 years ago, and the health department is very diligent in tracking down the source of infection, and it was tracked to wild turkey poop in our backyard. Because the older we have to ingest it, children can get it through transmission through their skin, and young babies can get it by inhalation. So with that being said, 3 years later, we got chickens. We were rural chicken farmers. And I became the chicken general because chickens are notorious salmonella carriers. So I was like gloves, boots, washing hands, wear a coat when you go in the chicken coop. Well, Nate was obviously not adhering to the general's rules. And I said, Nate, you don't want to get salmonella again. And he said, I liked having salmonella. And I reflected upon it, and I thought salmonella to him was 3 days of diarrhea and 2 months of staying home, even though he was just in preschool. But he got to stay home, and he has a twin brother who had to go to school, and he got to be with me or with his dad, who's a builder, and he got to go to work with him. So I thought, it's just such a good example that you have to know what your patient's agenda is, what are their desires, what is most important to them. They may be depressed, and they may not care that they have hypertension. They may be happy to be coming to visit you. They may not want to do lifestyle modifications because they have it in their mind that they need their medications, or they don't understand what a low sodium diet is. So seeing them and understanding what their needs are is so important. And also, I received my master's at Gonzaga University, and I try to carry this with me all the time, and it says that it was a Jesuit philosophy, and it says people learn what they want to know. So it's not what we want to tell them, it's what they want to know. So find out what they want to know, and then move from there. Health history for older adults. You want to know knowledge of past medical history will help to anticipate problems related to other conditions. Other cardiac risk factors, their level of physical activity, obesity, hypertension. Of course, you want to know about their current prescriptions, over-the-counter medications, alternative therapies. A lot of older adults, first off, they might not embrace alternative therapies, but then if they do embrace them, they're embarrassed and don't think it's anybody else's business to know about them. So you want to try to elicit that information. Are they on medication to treat lipid abnormalities? Are they on polypharmacy and they're not tolerating their meds, so they're selectively not taking things on alternative days or never? Undernourishment or malnourished nourishment is common in the elderly, and that may contribute to impaired cardiac function, making it vital that nutritional deficits be identified early and corrected. And because the clinical presentation of heart failure may include a variety of symptoms reflective of pulmonary congestion and decreased cardiac output, important health history aspects to include and observe during the health encounters are not only ask these questions, but to observe the patient for the following. Are they having difficulty breathing? Because after all, it's all subjective. And they may say no, but you're looking at them and say they're compromised, but that's a good day for them. So your observation and their perspective is also put together. Plus, I was sitting with Lori earlier, and she was telling me that asking the spouse is also very valuable, plus inquiring about their sleep habits. Not just how often are they sleeping, are they waking because they're breathless? Because it's been documented in studies, and I don't have any of the information here, but that desatting at night is a contributing factor to developing hypertension. And if these patients are treated with CPAP, that they don't desat and then can usurp the development of the hypertension. Are they having fatigue, weakness, a decrease in their exercise tolerance? Maybe they walk every day, but now it's starting, their routes getting shorter and shorter. Did they gain weight? Do they have weakness, dizziness, or lightheadedness? So on the physical examination, another point that I find very important, but we might all overlook, is the taking of the blood pressure. In most scenarios, as you know, it's done very fast and not like it should be. And we all learned how to do it in nursing school, and I can safely say that because it looked like most of us were nurses when she had us raise our hand. But every time I get my blood pressure taken, and I've tried to be more cognizant of it now when I take others' blood pressure, is to do it the right way like we learned in school. So what I'm saying is, when you take a blood pressure from now on, try to take it like a nursing student, and not just a nursing student, but a nursing student whose instructor's watching them, because they do things a lot differently that way. So, but a variety of environmental factors can influence blood pressure determination. Therefore, the room should be comfortable, the patient relaxed. There should be 5 minutes from the time they came in and sat down before you take it. There should be no clothing over their arm. They should be seated and their back and their legs supported. And the middle of the cuff on the upper arm should be at the level of the right atrium. The initial blood pressure should be taken in both arms, and the proper cuff size is crucial. As we all know, we come in all different shapes and sizes, but we usually have one blood pressure cuff that we use for everybody. So try to think of it like the bladder length should be at least 80% of the arm circumference, and width at least 40%. The midline of the bladder should be placed above the brachial artery, 2 to 3 centimeters above the antecubital fossa, where the artery should have been first palpated. And you take 2 readings. Take 2 readings 5 minutes apart and averaged, and if there is greater than 5 millimeter of mercury difference, additional readings should be obtained. When the oscillatory method, which remains the gold standard for blood pressure measurements, palpating the radial pulse first while inflating the cuff will identify the point at which the pulse disappears. And then from there, inflate it to at least 30 millimeters of mercury above that point. Now, am I saying anything that you guys forgot, or do you all take your blood pressures like this? Yeah, I don't want to be redundant, but I felt like it was a good reminder, because when I heard it, I was like, I've got to rethink my ways. And also, deflation is an extremely important rate, at 2 to 3 millimeters per second recommended. Pseudohypotension is a phenomenon resulting from non-compressibility of thickened arteries, and if not recognized, will result in the recording of falsely high BP when indirect methods are used. And this tendency for peripheral arteries to become rigid with aging may result in a need to increase pulse pressure in order to compress the artery. This is very common in the elderly, particularly in men or people with hypertension or stroke. And it says if you suspect it, then you're supposed to use a intra-arterial reading, but how do you suspect it? So, well, I guess you suspect it if you're treating someone who has progressively higher blood pressures, even with treatment, or immediately with treatment they start experiencing orthostatic hypertension problems, or with this extremely high blood pressure, there is no organ damage. You're not seeing any of these other signs and symptoms that go along with it. Also, the elderly are very susceptible to the white coat hypertension. They get nervous in the office, so sometimes ambulatory readings are better. Standing blood pressure should also be assessed because of the problem that's so common with the elderly is orthostatic, and I don't know how often it is done, but it should be done on every visit, and all you need to do is have them stand up and take their blood pressure. So what is a diagnosis of orthostatic hypotension? It's diagnosed when systolic BP falls at least by 20 and diastolic by 10 within 3 minutes of a change in position. Older adults with comorbidities who may be frail often require assistance from transitioning from supine position to sitting. Also, when you're doing a physical examination on an older adult, it's quite possible that the adult with heart failure may become increasingly fatigued with multiple changes in position. So you need to keep that in mind and try to preserve their energy as well as possible, either by limiting the amount of position changes that they need to do, or to take more time in between the position changes. And now with all the healthcare regulations or the insurance regulations, you know most physical examinations are supposed to be done really quick, but that's hard when you're trying to accommodate someone who's they're decompensated. The physical examination findings consistent with heart failure are the following, and that's all on your jump drive, so you can go ahead and look at that. And the clinical presentation of heart failure may be atypical in the elderly, and often the diagnosis is difficult. In the patient with diastolic heart failure, there's an increased resistance to passive filling of the ventricles during early diastole or relaxation. In contrast, there's a decrease in the contractility of the heart in systolic heart failure. So both the high ventricular filling pressure and the poor pumping ability of the heart can lead to pulmonary congestion and diminished cardiac output, resulting in a similar presentation of both diastolic and systolic hypertension. But however, it is important to distinguish the two as the management is influenced by the type of dysfunction that is present. Dyspnea may be absent, and although the presence of peripheral edema and basilar rales are common findings in the younger patient with heart failure, they're unreliable diagnostic signs in the elderly. With a low cardiac output and decrease in perfusion to the periphery and other organs, the patient may present with a gangrenous extremity, confusion, and worsening dementia. So a lot of patients, like I said, if it's a younger patient with heart failure, it's more typical that they'll have the typical presentation. But for the older patient, we're going to have to dig a little more deeply. And one of the exams that's so overlooked is the neurological assessment. And with changes in heart rate and rhythm, a decrease in cardiac output, and side effects of cardiac medications may cause significant change in mental status. And on one of the resources that I listed on the end of this presentation, there's a link to the geriatricrn.org, and it has geriatric topics, but there's two surveys to detect delirium and dementia in your clients, and they've been very successful. I have my students do them on a lot of their patients, because the elderly, as they come into the hospital especially, they get a little sleep deprived, and these tools are so valuable to use. And then not only when you use those, I make them show every time they use one of these surveys from one of these websites that are on the back. Two requirements is they have to show the primary nurse and the care provider, because I feel like that's a good way that we are spreading the word, so that these people with delirium, which they can die from delirium if it's gone too far, that it's more easily detected and more people are aware of tools we can use, so we just don't have to make subjective decisions about whether they're experiencing delirium or now they have dementia and they have to go to the nursing home. It's like, no, they're experiencing acute delirium from being in an acute situation, and they're on all kinds of cardiac meds, and they're desaturated and they haven't slept. So they're just wonderful tools that you can use. Other gastrointestinal symptoms, such as anorexia, postprandial hypotension, abdominal fullness, and fatigue during meals are common in elderly with heart failure. In advanced heart failure with restricted cardiac output, patients may have symptoms of mesenteric ischemia following meals. And also, patients on warfarin may develop an unexplained elevation in their ProTime due to hepatic congestion, signaling a worsening of the heart failure that is kind of like trying to warn us, because it's even prior to the development of overt symptoms. So if you see a spike in their ProTime, it could alert you that their heart failure is even worsening. Excuse me?